the surgical procedure itself is a potential risk for blood loss. And in view of that, it's important for us to be able to manage the volume of blood that is lost during the surgery. And from the previous presentation that we've done, one major, I always try to refer to the fact that surgical procedure is a three-legged practice. What do I mean by that? The pre-operative, the intraoperative, and the post-operative event. You know, the three major events that will determine the outcome of surgical intervention. So, which means that the examination of patient before patient come for surgery, and with emphasis on the blood volume, the blood level of the patient coming for surgery. It's important for us to understand that, okay, what exactly is the hematocrit level, the blood PCV, the blood volume. Of course, there are many parameters for us to get out of this. Number one, of course, the physical examination, you know, of a patient that is anemic by physical examination, the capillary refill, the conjunctival, patient that is pale, you know, and then of course, further to that, we collect blood sample for to check for the PCV level, the PCV, the hemoglobin, and all of that. So all of this information are baseline for us to know, you know, what is the blood level of the patient, and then of course to know the status of the patient before we go in for the surgical intervention, which of course is also another potential risk for blood loss, for additional blood loss, regardless of the status of the patient before we go for surgery. So now the other part of it is the surgical procedure that the patient is going for is very important as well. And then of course, under which of course, you know, want to do the surgical risk classification as to, okay, is the patient going to lose minimal, you know, you can anticipate that, okay, in this procedure, for example, maybe the procedure is superficial or minimally invasive procedure, maybe endoscopic procedure, or, you know, or moderately invasive procedure, or, you know, severe procedure, severely invasive procedure. So all of these are measures of to anticipate the average blood volume that will be lost, you know, that will be lost during the surgical intervention. So this can help, you know, to plan, because ultimately the essence, of course, the purpose of estimating blood loss is to plan, to know whether to plan to transfuse this patient or not. You know, that's the essence of, you know, assessing this patient, either to transfuse this patient or not, you know, post-op or even in trial. Therefore, it's important for us to assess, you know, to assess the patient even before the commencement of the surgery. However, now that the surgery is about to start, or the surgery has started proper, how do we estimate blood loss? How to estimate blood loss? Number one, we have the visual assessment, which of course is what we are you know, always been doing. We have the visual assessment, and we have the clinical assessment. Now, the visual assessment, we have the visual assessment and the clinical assessment. Now, it is said that the visual assessment are not always very reliable. So I just got home, so just to, sorry for those little distractions. Okay, so now the visual assessments are usually, you know, very not reliable. Hello, can you still hear me? I hope I'm still audible.
Yes, you're still audible, sir. We can hear you.
Yes, we can hear you.
Okay, thank you very much. Okay, so like I said, the visual assessment is, of course, the use of our visual special senses to assess the level of blood loss while the surgical procedure is going on. Now, like I said, it is said that visual assessment is not usually reliable. However, so we don't rely on visual assessment alone to determine the actual blood loss. Then, of course, when we're talking about actual blood loss and estimated blood loss, all of these is also a measure of the trigger volume. There's something we call trigger volume, which means that at what level do you consider this patient to receive blood? Because that's one of the major essence of, assessing the estimated blood loss. You want to know if this patient require blood transfusion while the surgery is going on or not. Okay, so now under visual assessment, we consider that blood loss that is more than 1,000 mil, 500 to 1,000, blood loss between the 500 and 1,000 mil. The total blood volume of a patient, of an average adult, is calculated by 70 mils multiplied by 70. So or let me say 70 mils total body weight for an average adult. 70 mils multiplied by average adult weight. However, for pediatrics, it's about 80 mils per kilogram body weight, and for neonates, 90 per kilogram body weight. So now it's a measure of total blood volume versus blood loss. So in a patient that has lost about 500 to 1,000 mils of blood in surgery, at that level, body is compensating. But if it's more than 500 mil, you consider that it's mild. If it is more than 2,000 mils, it's moderate. And if it is more than 3,000 mils, it's considered to be severe. Now, the total blood volume, for example, is about, for an average adult, is about 5 liters. So someone who's already losing about 3,000 mils of blood in surgery has lost more than 60% of the total blood volume. In fact, as a matter of fact, you will not even wait for that. From this, it's between 2,000 and 3,000 mils is already considered to be severe. So 2,000 mils of blood is about 40% of the total blood volume. So what do I want to bring out of this conversation is that any patient that is already losing up to 2,000 mils of blood has already lost so much. We consider it as severe blood loss. And in a severe blood loss, we recommend massive blood transfusion. And that's why blood transfusion in the theater is different from the blood transfusion in the ward, because you are replacing an ongoing loss. And most cases, we always prefer that when the patient is losing blood, that's not the best time to transfuse the blood. Ensure that the surgical team has maintained hemostasis. Otherwise, whatever you are transfusing again, patient is losing it at the same time. Apart from the actual blood loss, like I said, other thing that we're also looking at is the blood pressure, or let me say the clinical findings, the blood pressure, which is usually the blood pressure and the heart rate. Of course, at the level at which patient is compensating, when patient is compensating, there's really nothing much, no changes per se in the blood pressure. And of course, it means that the body is compensating well. There might not be much changes in the blood pressure and the heart rate. However, there's going to be a slight fall in the blood pressure when it's already becoming mild, maybe about 80, falling down to about 80 to 100. That's systolic. Systolic blood pressure. By the time you're having systolic blood pressure of about 100 and is downward trend as low as 80, is already slight fall. Now you are seeing marked fall when it's going below 80, and it's become severe when it's going below 50. Of course, at this point in time, it's already a very bad situation. It depends on who is monitoring, and of course, the attention, the alertness of the surgical team, every member of the surgical team, to respond quickly as quickly as possible. And that's only when you can probably save the situation. However, if not identified on time,
this is a situation where, patient can go into cardiopulmonary arrest while surgical procedure is going on. So we said that, changes in the blood pressure that is already showing on the monitor, blood pressure and heart rate, that about 1/3 of the total blood volume is already lost. Or sometimes in a patient where that you are doing an awkward position in surgery. Maybe the patient that you are doing, maybe you are doing spine surgery and the patient is in awkward position like prone position or lateral positions. You could also have what we call orthostatic hypotension, which will drop the blood pressure to about 20 to 25% over, of the initial blood pressure. Okay, so the next that we want to check is also the measure of the hematocrit, which is the PCV. Now, the measure of the PCV usually is not reliable until about 48 hours after surgery. But for the first 4 hours of patient blood loss, it said that, for example, for about 500 minutes of blood loss in surgery, the hematocrit level would decrease by 3%. For average of about 500 minutes of blood loss while surgery is going on. If you check that PCV at that moment, of course, a drop about 3% in the total blood volume is what is going to show on the PCV. However, if in a situation where as you give the blood, as you are losing the blood, you are giving the blood at the same time, it might not become very obvious. It might not be very obvious yet until about 48 hours later, when after the surgery post-op, 48 hours post-op, when all the hemodynamic redistribution will have taken place. And that's when you can actually get the actual PCV of the patient. So what am I saying in essence? The take-home message, if I may have to repeat myself on that, using PCV as a measure of the blood loss is not an accurate figure until about 48 hours post-op. Of course, it cannot give us that. Definitely, that means that's not reliable enough for us alone, to tell us either the patient is losing blood or not. But then, of course, at the post-op, like I said, the post-op management is also a factor. The pre-op assessment, the intraoperative ongoing blood loss, and the transfusion of blood and the replacement of blood loss. And then, of course, the post-op management, which, of course, at the post-op level, at the post-op management level, you check for the PCV to confirm if patients will require blood transfusion or not. Otherwise, the suture sites might not heal by first intention. And that's why you can have, cases where patients come down with wound gaping, breakdown of suture lines, wound breakdown and all of that. So these are some of the things that cause that. So before the patient is asked to, patient totally discharged from the ward, you want to confirm that the estimated blood loss, the blood loss in surgery has not really affected the patient's hemodynamic equilibrium. Now, another major thing that also can be used to measure blood loss in surgery is urine output. Hello, can you hear me?
Yes.
Okay.
Yes, sir.
All right. Okay. Thank you. So another measure of blood loss in surgery or in operating room is urine output. I want us to understand that, in most cases, part of the thing that we measure, estimated blood loss, urinary output, fluid intake, intraoperative fluid intake, and all of that. Most time, many people probably don't understand
Sir,
that.
we can hear you. Yes.
Okay.
Hello.
Hello. Hello.
Go on, sir. We can hear you.
Okay. All right. Okay. Now, a lot of time we probably don't understand the importance of that urine output that we measure. We probably thought it's just a measure of fluid intake while the surgery was going on. However, it's important for us to understand that perfusion pressure of the vital organs is a measure of how much of blood that have been lost in that surgery. And some of the vital organs that we check, of course, we are checking the vital organs like heart, checking liver, brain, kidney as well. Of course, brain patient is already asleep, so you might not be able to even know. Although, of course, your mean arterial pressure can tell you if you are, of course, or you are doing cerebral perfusion pressure, maybe like a brain cerebral monitor whatsoever that can tell you the cerebral perfusion pressure. But then patient is already unconscious. So clinically, you might not even be able to pick whether the patient is getting enough perfusion to the brain, except you are doing a neurosurgery. That in neurosurgery, you can do hypotensive anesthesia for you to know that, you know, probably to show that they can work on the brain without being brain tissue or brain matter under tension. However, for all forms of surgery, urine output is a measure of either the kidney is perfused. And you know, when the blood is carried to the kidney properly, of course, what's going to happen? The functions of the kidney is going to be optimum or optimal. Of course, and we all know the function of the kidney, which is filtration, secretions, and selective reabsorption. And at that level is until the kidney is properly perfused that you can see and you can assess it by the urine output. In a concentrated urine output, you and I know that that patient is already, you know, patient is either dehydrated or, you know, or is anemic, you know. So patient might be, you know, so so it's a measure of, it's a measure of fluid and it's a measure of perfusion pressure when you are checking the urine output. So one of the most important vital signs to follow in the bleeding patient with in surgery is the ability to diurese, and of course is a measure of how much of blood is perfused to the brain, to the kidney. And you know, if the kidney is not perfused, it won't perform its function. So it's a measure of blood loss. Sorry. Okay, so another thing like which we are very familiar with is the weighing of packs. You know, we know that 4x4 gauze, you know. So what we say is that for the gauze, for the abdo pack, 4x4 gauze, and any other size of gauze that we use in our center, you know, is, of course, we are, as perioperative nurses, we are very familiar with this method. You know, and the accurate way to measure, we consider that, you know, each gauze, if they are fully soaked, is about 10 grams, which of course, it is calculated that each gram represents is a measure of 1 ml of blood. So if a gauze, a proper retake gauze, not the, you know, the actual one, or the other way to do about it is if you have weighing scale in our operating room, is to actually get the actual weight of those gauzes, each of them, and then so that for us to understand, to appreciate, you know, blood loss in surgery, if we actually want to do it as a study, so that to confirm either whatever we are doing is actually empirical or it can be confirmed clinically. So yeah, so we are doing measure of the packs, either the gauze, the 4x4 gauze, or the lap pack. Now, they said the easiest method of estimating is to picture it. So I don't want to bore us with much right talk. So summarily, that's what, you know, using of facts to identify, you know, blood loss in surgery. So the other ones is, you know, measurement of actual blood loss. You know, in some situations, especially in pediatrics, you don't use estimated blood loss. In pediatric surgery, you actually want to get the accurate, you know, blood loss. And the reason is because by the virtue of in children, you don't want to, for every single unit of blood that is lost in children, you want to replace them back. Because the threshold for blood loss in children is not as much, is not as much as, you know, in adult patients. So you want to reduce, you know, the blood loss as much as possible. And so because of that, it's not enough for us to, you know, rely on. So let me quickly go back on the urine output. Let me mention this point. Now, what is the target for us to know that the patient is actually making adequate urine in surgery? So the question is, what is the target urine output for us to know that, oh, this patient is actually well perfused and the vital organs are also well perfused? So the average is about 30 mils to 60 mils per hour, which comes to about 0.5 to 1 kilogram per 0.5 to 1 mil per kilogram body weight. So which means that average of 0.5 mils in an adult. In children, 1 to 2 mils. In neonates, 2 to 4 mils per kilogram body weight. But in an average adult, you expect that the patient should make at least half the volume, which is equivalent to their weight. If a patient is weighing about 70 kg, for example, you expect that this patient should make about 35 mils of urine in 1 hour, and which minimum, and the maximum was about 70 mils in 1 hour. So the target is actually to get the maximum figure. But however, if you cannot get the maximum figure, don't go below the minimum figure. I mean. So that's the target. I've mentioned the weighing parts, and then okay. So the other thing is surface area. Sometimes blood are not. Of course, we have blood loss on the surface, on the floor. We have blood loss on the gown, on the drapes. So we assume that you know, some of these might, just like we said, is an estimated value. However, the one that is on the floor, it's considered that if it's a small area like 10 by 10 centimeter in measure, it's estimated to be about if it's about 50 centimeter, that's about 50 centimeter diameter on the floor. It's estimated to be about 500 mils. So we can put a measure, you know, of about 50 centimeter diameter. Diameter, diameter means circumference. If in the circumference, the diameter is the line in between that connects the two ends of a circumference. So if it's measured up to 50 centimeter diameter, that's about 500 mils. If it's measured about 75 centimeter diameter, that's about 1,000 mil. And if measured about 100 centimeter diameter, that's about 1,500 mil. So it's estimated. However, another condition, another caveat, another exception to that is if you're having clotted blood, like I said, you know, it's still put as estimated volume. So you might not necessarily get, if you are able to get close to the accurate volume, it's enough to determine either the patient will require intervention or the body can, you know, readjust back to the patient can readjust back to the preoperative blood requirement, blood volume requirement, or accurate ideal blood requirements. All right, okay. So the actual blood loss, like I said, like in a population of pediatric cases, you want actual blood loss, not the estimated blood loss. And of course, in some situations, some patients are very frail and fragile. So in this kind of situation, we consider what we call trigger volume or trigger PCV. And that's what will lead us to getting the actual blood loss. If some patient, like I said, in pediatrics, or in some adult cases that are very frail and fragile, maybe the patient is extreme of ages, or probably very elderly, or patient is bad, in a very bad situation, or patient post-traumatic patient that presents in the ER and was transferred to theater, you don't want estimated, you want the actual blood loss. So that's, in this kind of patients, you need a value of the initial PCV and the value of the final PCV, and then divided by 2. So now, how do we do that calculation? The value of the blood volume by initial PCV, the post-op PCV, the post-op PCV that you expect, then you minus each other. For example, if the patient coming with a PCV, if the patient has a PCV of, for example, patient coming with a PCV, the ideal PCV for an adult, an average adult is about maybe a male adult is about 45%. What you can allow to happen is maybe the minimum, or the presenting PCV is about 30%. You minus the ideal PCV from the patient presentation of a PCV, and then you divide it by the mean of the two value. So if patients, the ideal PCV for a male adult is about 45%. Maybe the presenting PCV now is 25%. So the mean of the two is 45 minus 25. That's 20 divided by 2. That's 10. So you 45 minus 25 divided by 10. And the PCV of the patient, like I said, for every drop of 500 mils in blood, in every drop of 500 mils, it will reflect in the PCV as 3%. So for the final value of the PCV that you get, you can estimate the volume of blood that will be required, or that you can allow to that can be allowed for that patient to lose in surgery. And so if you already have this at the back of your mind, you can program, you can schedule to have a particular number of blood ready before the surgery is done, that this is how much I can allow to happen in this surgery. So these are some of the things that we try to do. Like I said earlier too, an average adult, about 70 ml per kilogram body weight is the total blood volume. For neonates, about 85 to 90 ml per kilogram body weight. And for children, 80 ml per kilogram body weight. So you can use that to calculate ideal blood volume, and then from where you can get, your PCV level for each age category. Oh, sorry. So I've mentioned weighing of dry swab. I've mentioned, and I told us that each means of blood, the swab, each gram of blood of gauze is 1 ml of blood. And then, of course, we also have blood collected in the suction machine, which, of course, it can be also measured. Either we measure the weight of the suction machine before the surgery and deduct it from the final weight of the blood of the suction machine after the surgery, for us to know for each gram is also equal to each gram is equal to 1 ml, for us to know the blood loss. Or we can empty the blood in the suction machine into a container, into a calibrated container, for us to actually a standardized calibrated container for us to know the actual blood loss. So I mentioned surgical drapes, blood loss in surgical drapes, pulled beneath the patient and onto the floor. So all of this can also be measured as an average volume. And then, of course, volume of irrigation can also be subtracted from, if you have to irrigate this patient, maybe some surgery required that you irrigate, or in a situation where maybe patients, maybe body fluid or pus is mixed up, to be able to differentiate in this category of patients. So these are some of the things that have been mentioned. Like I said, depending on the condition of the patient before you start the surgery, that will determine the amount of blood that you can allow in that patient. Yeah, so I've mentioned, I think quite a point that I've mentioned among the ones I listed here. So, okay, so I also have a point here that I talked about, like I said, the trigger volume. I think I mentioned it, the allowable blood loss in a surgery where patient is, so we said the blood volume multiplied by the pre-op and the lowest acceptable blood. So if the patient's, so the patient blood volume, the initial PCV minus the least PCV that you can ever allow. So meaning that you can predetermine that, okay, in this patient, I cannot, anything less than 30% PCV is not, I can't take it. So you can predict the allowable blood loss. So the calculation is blood volume multiplied by the difference of the pre-op PCV and the lowest PCV that you can ever allow. So the pre-op PCV and the lowest PCV you can ever allow in brackets minus each other, multiplied by the total blood volume of the patient over average of pre-op and lowest. So I think I mentioned it earlier, so that's how you can determine that if I have a blood loss that's more than 500, that's how you can determine either if I have a blood loss that's more than 500 mils, then I have to transfuse this patient. Otherwise, it might be, a very disastrous situation at the end of the day. So these are how to monitor, other patients will require blood transfusion while the surgery is going on or not. Wow, so far so good. So if you're able to say, the American College of Physicians recommend that blood transfusion should be done unit by unit, and the patient should be evaluated between each transfusion. Excessive intraoperative transfusion and practice of administering blood without ever evaluating the hematocrit in between resulted in 90% of unnecessary blood transfusion. Determination of the hematocrit immediately before admission of each unit will reduce blood consumption by 25%. So, in conclusion, so what this is talking about is that we are trying to avoid over transfusion, and we're also trying to avoid under transfusion, and that is the essence of estimated blood loss while in surgery. And I think in this presentation, I've been able to tell us more than what the conventional weighing of gauze. We also look at measurements of the surface area. I've talked about the 50 cm, the 75 cm, and the 100 cm. I've talked about the urine output as a measure of even with blood perfusion. I've talked to us about using the initial PCV and the postoperative PCV to know whether the patient will require blood transfusion. And I've also told us about use of allowable blood loss as a measure of if the patient will require blood transfusion postoperatively. At this point, I want to rest my case. Thank you for the opportunity to present.
Wow, thank you, sir. Thank you. I really learned a lot from your presentation. That was a very, very wonderful presentation. Thank you for taking out the time to be here and give us this wonderful and educative lesson. So we'll be moving to WhatsApp right now for the question and answer session, and then concluding, and for further announcements if there will be any. So if you're still online, please can you unmute and appreciate our presenter, Ms.